and or not miss a diagnosis. Get your physical exam skills down to do them quickly but completely and thoroughly. Then you can spend a lot more time doing all the counseling and all the stuff that we actually value. So the patient doesn't feel rushed at the end of the visit trying to get all of their treatment plans, understanding how to take their supplements or medications, etc. So really think about your algorithm and your process and trying to pare it down to the relevant history and physical exam. The other pieces that you need in documentation is, of course, your assessment, impression, or diagnosis, medical plan of care, so your treatment plan. If it's not documented, the rationale for ordering a diagnostic test or ancillary services should be inferred. That goes to the previous slide as far as, is it implicit? Person is fatigued, I'm ordering a CBC. That's pretty clear why you would be doing that. Or if it's not easily inferred, then you need to give them a little statement as to why you're ordering that. Past and present diagnoses should be accessible to others. There was a question that came in about a cover sheet. This is the cover sheet piece. So if you're doing a paper chart, then a cover sheet would be just a simple, I built mine in a Word document, of their problem list, all the different diagnoses that have come in over time, the date they started, the date they resolved, past surgeries, a quick, when was their last pap smear, other providers. So that's a cover sheet, just a quick synopsis. And if you think about it, if you share a practice with anyone and someone else who needs to cover for you, that should be the cheat sheet. Another doctor in your office who's seeing someone acutely should be able to glance at this one piece of paper and know exactly or pretty much what's going on with this patient and not have to read the whole chart. That's what a cover sheet is. In EMRs, it's typically the face sheet. So EMRs typically have that built in, and you just need to make sure you keep it current. That's the biggest piece, is if you don't keep these current, they're not any help to you. And Bob asked a question as far as, does it need to be submitted with the HCFA? I'm presuming he's talking about the cover sheet, or that person is speaking about the cover sheet. And no, this is in your chart note. The only thing that goes on the HCFA is your ICD-9 codes, soon to be ICD-10, and your CPT codes. They don't care about any of the other items. The other thing that you're going to want to include, which is not on this slide, but you are going to want to make sure that you also have a med sheet. Again, something very quick and easy. EMRs have this built in automatically. If you do paper charts, think about just making a really quick grid in Excel and printing that out, and you can then very quickly and easily during every patient visit go through. Are you still taking your probiotics? Yes, check. Are you still taking atenolol? Yes, check. And you can run down the med sheet, check, check, check. Nope, I discontinued that. No, we changed the dose of that. Now you don't have to chart all of that stuff verbatim. You can just reference the med sheet, and you can do this in EMR, EHRs as well. Reference one line in your chart note. See updated med list, and you put the date. Done. And now you're managing medications. And as we'll see, managing medications is a point on your complexity. That's brain power. You're thinking about drug-herb interactions, you're managing medications and refills and drug-drug interactions. So even though we do it every day, that's the piece I'd say we forget, because it seems so simple to us after we've had some experience with it, but really there's a whole bunch of thought process that's happening there. So